Well, thank you very much. We're going to begin. We have a final 1-hour session here, and I'm going to hand off on the official moderating duties. And the moderator for this session is going to be Stephen Palmer. And Stephen Palmer is the director of the Office of eHealth Coordination for the Texas Health and Human Services Commission. So with that, I'll hand it over to you, Steve.
Great. Thanks very much, Vivian, and it's good to see so many people here today. Again, my name is Stephen Palmer. I'm the director of the Office of eHealth Coordination with the Texas Health and Human Services Commission, and I serve as the state health IT coordinator, implementing a number of through my office, coordinating the implementation of a number of the programs that Dr. Blumenthal described earlier, at least at the state level. I'm happy to have two distinguished physicians and thought leaders in the health IT space join me today. Dr. John Joe and Dr. Ken Shine. Y'all can read the details of their biographies in your program. I've had the pleasure of working with both Drs. Joe and Shine on a number of initiatives over the past several years. Dr. Joe is a Chief Medical Information Officer and physician and Associate Professor of Medical Informatics, and also a serial entrepreneur in the health IT industry. And Dr. Shine, of course, is Deputy Executive Chancellor at the University of Texas System over the health services, and has a distinguished career having worked for the Institute of Medicine and for academic medicine in California. With that, I'd like to go ahead and just kick it over to our presenters. I believe, Dr. Joe, you're going to be starting. Is that right? Or Dr. Shine?
Well, I'll be happy to start, I guess. First of all, let me join Ambassador Durgin and Vivian in welcoming everybody. The University of Texas is pleased to be a co-sponsor of this event. Secondly, in the interest of public disclosure, I am on the board of directors of United Health Group, which includes an insurance company and a series of other organizations involved in for example, Ingenix does work in electronic health records, and there are consulting groups and so forth, so you need to be aware of that potential conflict of interest. The American healthcare non-system is the most expensive in the world. It costs more both in absolute terms per patient and in aggregate, and as a percentage of GDP than any other system in the world, but it produces significantly less for those dollars than those dollars merit. In almost every area of healthcare quality that one might measure, the United States healthcare system ranks in the high teens in terms of comparisons with other countries. Moreover, if you look, as the Commonwealth Fund has done, at 6 healthcare systems in comparable industrialized nations, we rank 6th in essentially every parameter that's measured. As the quality of care in this country, on average, is mediocre at best. When it is when we're at the top of our game, we give extraordinary care. But as Beth McGlynn demonstrated years ago, and all of the data since that time has documented, on average in this country, when a patient has an interaction with a physician, that patient will receive optimal care approximately 52% of the time. And that's what we're paying almost twice as much for per individual than other countries which have far better results. That is not to say that health status is not a function of many other factors beside the healthcare system, but you have to ask yourself, in fact, are we getting what we're paying for? Moreover, it is the largest cottage industry in the world. Our cottages are very large. They have high-tech equipment in them, but they are run like mom-and-pop operations. Until very recently, they had no knowledge about their costs, and in many cases, they still do not. If you try to find out what it costs to provide a particular kind of care in the American healthcare system, it's almost impossible to determine that. The cost accounting systems are antiquated. Hospitals will charge whatever they need to charge in order to balance their books. That's why you have $3 aspirins. That's why you buy the next generation of monitoring equipment for the intensive care unit that costs significantly less than the previous generation, and the cost per day of the stay in the intensive care unit goes up as opposed to going down. Many of us, including us, we're working with the McCombs School of Business at UT Austin to come up with modern cost accounting methodologies to understand what our costs are. Our information systems suffer from the same problems. And although you heard from Bill Stead, who is arguably one of the two or three, if not the leading individual in terms of the use of electronic systems to manage health enterprises, if you look, with the exception of one or two of these systems, the state of the health information technology in the American healthcare system is terrible. Can you imagine sending a package with FedEx and not being able to find out where it is? Yet ask yourself, do you know where your patients are when they come into the emergency room or when they come into the clinic, or even if they're in an inpatient bed? Can you tell in most institutions where the record is? And I'll remind you that as recently as 8 years ago, if a patient was seen in an emergency room on a weekend, the weekend after they were discharged from that hospital, 30% of the time, one couldn't find the patient record. We would not consider any successful business or industry to be operating with a level of computer support and information technology that we tolerate in the American healthcare system. So from my perspective, it's not about how much it costs. It has to be, those costs have to be paid, because we must somehow bring the American healthcare system into a system, and one which is appropriate to the 21st century. If we don't, then we look at the most recent estimates on the costs of inflation in healthcare. And even with the concessions made in the negotiations for the Affordable Care Act, the estimate is that healthcare costs will continue to rise at about 6.9% per year. Ladies and gentlemen, we're looking at, if we're lucky, growth rates in the gross domestic product of maybe 3 or 3.5% per year in the next several years, if we're lucky in bringing the economy back. But that emphasizes that the costs in healthcare are significantly greater than the costs associated, than the overall gross domestic product. Medicare will run out of money, and as you heard, the current level, we would be close to 20% of GDP by 2020. That can't go on. Now, we said that, some of you may know that Michael Crichton's first book was called 5 Patients. I recommend it to you because it's a remarkable description of what healthcare was like in the early 60s. At that time, healthcare was 6% of the gross domestic product, and he thought might go up another percentage or two. But it can't go up much higher than that. The fact is that the national debt is rising so rapidly that it has become a number one primary goal of the American people to see it controlled. Moreover, America's position in terms of world economics is such that we cannot compete with healthcare costs that high. We simply cannot produce products in which the cost to industry represent that high degree of cost and compete with products that can be made in other parts of the world. Intellectually, we're at great risk because increasingly some of the best talent which came from other parts of the country to share the American dream is now going back to other parts of the world. With that, then, we have to ask ourselves, who can afford the current system, and what are we going to do to fix it? I would argue, as echoing some of the things that we heard this morning, that an effective and that's a very important word. An effective application of health information technology is essential, and I'm going to cite a couple of examples of that from the point of view of populations in a few moments. I think that one of the important developments that we've seen in the University of Texas is that whereas our research-intensive institutions have up to now not seen quality of care and information technology as being a top priority, today they all do. And we now have chief quality officers. We have the Center for Clinical Care Excellence at MD Anderson. We have collaborations of people in IT with the quality folks. That's new. And the fact that academics are involved with that is an important statement in terms of the possibilities. You've already heard that there are 4 regional extension centers in Texas, and I believe that they are going to be essential to carrying out some of the ideas which Bill Stead reflected on this morning. And as I think was pointed out by David Blumenthal, our School of Informatics at Houston received a $15 million grant as part of a program to look at the way in which cognitive function can be integrated into health information technology. All of these are very important developments. Finally, I mentioned that we are using meaningful use as an example or as a methodology, not just an example, as a methodology to agree on meaningful use quality measures across our system. We're spending a lot of money to develop information systems to be able to then cone down on whether and how those meaningful use information can be collected, can be analyzed, can be compared, and we can look at the outcomes of care across a fairly large system in terms of numbers of patients. Let me then spend the last part of my comments talking about this issue of costs and the implications for Texas. First of all, I would like to emphasize that the Affordable Care Act is supposed to cover some 94% of Americans in terms of health care coverage. Don't count on that for Texas. Texas currently has 25.6% of its population uninsured, but of them, at least a quarter are undocumented. And undocumented folks are not covered by Medicaid, and they're not going to be covered through the health insurance exchanges. Secondly, Texas is a state of small businesses, a higher proportion than in other parts of this country. Small businesses have a mandate to provide coverage, but there's a very minimal penalty to pay, at least in the next several years, if you don't provide coverage. If you're a small business person in the current climate facing real problems economically, would you rather pay the fine or provide coverage? There's similarly individual mandate, but again, the same applies. The penalty for that, at least for the next several years, is relatively small if you get caught. My estimate is that across the state, the percentage of uninsured will be 8 to 12%. Tom Sees, who's the Executive Commissioner for Health, has estimated 12%. In Houston, I believe it'll be 16% plus or minus because of your high proportion of undocumented individuals in this community. That being said, they are not directly eligible for funding for electronic health records. We've noticed that the funding comes through Medicare and Medicaid. So for them to be covered under an electronic health record, and remember, they're very expensive because when you have a patient with no insurance, they go to one clinic, then to an emergency room, then to another clinic. Nobody knows what happened at the other place. They get tests repeated. They get drugs given willy-nilly. There are examples in Central Texas of the Central Texas Collaborative, which at least gives an identification number for people who are uninsured. But we need a consistent approach in the state for that large population who are afraid to give identifiers because they're undocumented, but need to be protected. Secondly, we need to support the federally qualified health centers where they do see a lot of Medicaid patients so that the money that comes available for Medicaid providers can be used to provide care for the uninsured. Secondly, we have a major problem in Texas with regard to the size of the workforce to deal with that additional coverage. For example, Texas has 160 or so hands-on physicians per 100,000 population. The national average for physicians is over 240 per 100,000. So you already start behind the 8 ball. Having said that, because we have so many uninsured people in Texas, we're likely to add of the order of 2.8 million people to Medicaid, plus some other people getting coverage. So in a state that's already short of physicians, we are going to be even shorter of, obviously if you're in the Texas Medical Center, or if you're in parts of Dallas, some other major metropolitan areas where there's a concentration of docs, you may be able to take care of a significant amount of additional patients. But overall, it's not going to be feasible for this to be a physician-centric activity, nor to be a primary care activity, given the way in which physicians are dealing with primary care. In that regard, we are pleased that the legislature did approve $160,000 for over 4 years for loan repayment for individuals who would go into primary care, and we hope that that will encourage people to do it. But what are the implications of these two phenomena, namely the increase, the rising costs and the shortages in the workplace? The implications, I think, are clear. We have to have new delivery models, and we have to have new reimbursement models. I don't know any other way that we're going to accomplish the point that Bill made about looking at, I'm not sure it's going to be 25% against current costs, but I think it's going to be 25% from where the hockey puck would be in 2014. We're going to see enormous pressure to control costs in an environment in which the federal deficit has been so high and growing, and in which we have to have control of it. And I see no way to deal with that other than through new delivery models and through new reimbursement models. We've already heard reference to some of the delivery models. One of them is the so-called medical home. We call them health homes in Texas because we include dental care and other social services. But I would emphasize to you that those homes, which were originally conceived of by our colleagues in pediatrics as being primarily for primary care, will have to be much more diverse than that. And we can see the notion for health homes for people with congestive heart failure, health homes for people with cancer, etc. And we already know from experiments in Galveston that having patients with congestive heart failure, diabetes, and hypertension in a health home reduces emergency room visits by 62% and reduces hospital days by 50%. The importance of the health home and medical home concept is that it is indeed a team concept, which requires 24/7 coverage, which requires a team so that a substantial amount of the care is not given by the physician, but by others, particularly nurses and physician's assistants, but for which an electronic health record is essential. You can't pull it off unless you have the information available 24/7 and unless it's available to the whole team. There are other similar models, and you've heard reference to accountable care organizations. Accountable care organizations, as visualized, still are going to be very difficult to implement. And my prediction is that at least for the next several years, they're going to be largely hospital-based activities with a hospital as the central owner of the accountable care organization in collaboration with physicians, unless physicians' organizations themselves become much more proactive in trying to get control of the concept. But the deep pockets for the moment in the organization expertise is in the hospital systems, and they're moving very aggressively to find populations that they can care for. Caring for those populations and including the physicians who will provide the care will require electronic health records. You simply can't have a system of care that's going to be cost effective. And remember, both of these models, the health home and the accountable care organization, ultimately is designed so that they will provide more efficient care where you measure outcomes rather than procedures, where you pay a flat rate or some combination of a flat rate and fee-for-service, and where if you do a good job, there's some savings. One of the issues will be who gets the savings. And again, physicians are going to have to be very proactive in terms of how the pie is cut at that time, but that means that they're going to have to be leaders in doing it. Gain sharing clearly will happen to an increasing extent, in a variety of models where if money can be saved in the care of patients, there will be some increase, some gain in terms of savings, and that will have to be shared. That will provide incentives to control costs and to provide more money to share. And there is no question that pay for performance is going to happen. It's going to increase in prevalence. One of the real challenges to the medical profession is whether they're going to let somebody else decide what performance to pay for, as opposed to whether, as physicians, they can identify what kind of performance to measure and have those items be those that are paid for. It's one of the reasons why in the University of Texas we're so interested in measuring outcomes, so we can define what should be paid for. But pay for performance requires data, requires information, and over a period of time it will require attention to trends. It's all very well to have a pay for performance which shows what happens in this year compared to the next year. And most of these pay for performance activities, you get the low-hanging fruit very early, but then sustaining that is extraordinarily difficult. That requires trend analysis rather than raw data, and that requires effective activities with regard to the electronic health record. So I would argue, aside from any issues of quality of care, which is obviously extremely important to all of us, that the issue of healthcare costs and the pressures on the system over the next several years are going to be enormously dependent on how you deliver that care. And finally, we believe that mechanisms such as bundling of payment, in fact, makes a great deal of sense. Bundling involves a situation in which you pay for an episode of care, not just the operation or the hospital care, but a knee replacement, for example, and you pay for 1 year or 2 years of care connected to that. That gets at several issues. One, it again puts an emphasis on doing only what it is you need to do, rather than to do lots of procedures to generate money. But there has to be a flat payment for that. That flat payment then has to be divided between nurses, doctors, pharmacists, occupational therapists, all the people involved in care, which is a real challenge, but can be done. It's been done for a long time in transplantation programs. And we've seen in San Antonio, for example, orthopedic procedures bundled. And in fact, what's happening in San Antonio in the Baptist system is that the doctors are regularly getting checks, either monthly or quarterly, because in fact they've controlled costs. Not having as many prostheses, different things on the inventory with regard to replacing knees or hips. It becomes in their interest to improve to reduce the costs of care. However, neither the public nor providers will be satisfied with that kind of approach unless you measure the outcomes, unless you can show that quality of care is maintained, that the patients are satisfied, that you're not saving money at their expense. You need electronic health records. You need the data, and you need to be able to show those kinds of activities. So I'm making an economic argument for Texas. Those of you who know that of my involvement with the quality chasm and to err is human and so forth understand I've got perfectly good credentials with regard to safety and quality, and I'll be glad to tell you what we're doing about both of those. But I'm making a different argument. I'm making the argument that either society or we as individuals are going to have to pay for health care over the next 10 to 15 years, assuming that some of us live that long. And it becomes critically important that we recognize that controlling costs is essential. And I don't see any way to do that in the current system. I believe there have to be new ways to deliver care, new ways to reimburse, and that the electronic health record will be central to that. Thank you.
Well, thank you very much, Dr. Shine. And my plan, and I should have said this on the front end, is to let both of these speakers kind of give their spiel, and then take questions from the audience and kind of prompts for some questions as appropriate. So we'll go ahead and move on to Dr. Zhou.
First of all, I want to thank Vivian Ho and the Baker Institute for the opportunity to speak with you today and to be part of this distinguished panel. I'm going to continue the theme of cost in the arena of health information technology. Can Houston and Texas afford this? I'm going to cover three primary areas: the cost of implementing health information technology, primarily in the hospital arena and also in community-wide health information exchange. The physician office costs have come down dramatically in the last several years, particularly with the advent of software as a service or off-site hosting of electronic health record products. So I believe that there's a path towards affordability, perhaps not usability, but a path towards affordability at this point. Secondly, I'm going to talk about the cost of not implementing health IT. What are the factors in our community that affect hospitals and our community, and the trends that make it a bad decision, I think, to not invest in health IT? And then finally, what kinds of return on investments can we expect or hope for when we make those investments? So first of all, the hospital electronic health records. I want to talk a little bit about what's been happening in Houston. Our systems are fairly competitive, so I'm using only publicly available information, and this was published in the Houston Business Journal actually 4 years ago. And as you can see from the extent of the money that had been spent even 4 years ago, we have significant investments in our community. Texas Children's Health System had spent $60 million on a new comprehensive business and clinical information system. The Methodist Health System, $43 million. And MD Anderson Cancer Center has a combination of commercial products and is developing their own in-house electronic health record, with more than 700 employees in total in the IT department, and over 10% of those, at least a couple of years ago, involved in writing code for its own application. So you can imagine there are a few $1 million invested just in the salaries of those individuals. It's probably safe to say that there's over $250 million, at least 4 years ago, being invested in the clinical information systems in the Texas Medical Center. And I would think that it's safe to say that now, in 2010, there's at least $500 million being spent in the greater Houston community on clinical information systems. Just last month, McKinsey Quarterly outlined their evaluation of the cost for fully outfitting a hospital with electronic health records. This is not just computerized physician order entry, but complete documentation, medication management, and closed-loop ordering or medication management, the complete picture. So the average cost that they came up with, looking at a typical hospital in the U.S. of 200 beds, was in the surprising range of $80,000 to $100,000 per bed. Only a quarter of that or so, or less than a quarter, is attributed to clinical software licenses, $20,000 to $22,000. The single largest component of this cost is in the external, it could be also internal, but it's the implementation, the consulting process, the professional services. This assumes an ideal model where software is simply not incorporated to automate existing processes, but involves a complete evaluation of the existing state and the best practices and the gaps that exist between the current and the best practices, and designing processes and workflows to actually bring about clinical transformation. When things are done right, things are expensive in clinical IT. At the same time, in the article, McKinsey Quarterly pointed out that when you break down the potential dollars from the American Recovery and Reinvestment Act, the dollars that would offset some of the health IT investments in the electronic health record arena are only about 18% of that $80,000 to $100,000 per bed. Their estimation is that in a high-end implementation, only $17,500 would be recovered per bed against those costs earlier to implement a comprehensive system. Now let's turn to the costs in the community-wide health information exchange. Houston is a complex environment. As the numbers earlier should illustrate, people are making investments, health systems are investing in technologies and reaching out those technologies out into the community practices that are affiliated with those health systems. But we haven't had significant activity across the health systems and across providers that compete. I've looked around the country for examples of similar environments to ours that have been successful in gaining consensus and putting in a technology infrastructure that results in better outcomes. One of the best examples that I can find is in New York City, in Manhattan, the New York Clinical Information Exchange. It's a nonprofit 501c3 that was actually incorporated nearly 5 years ago. They did not actually become operational until early 2009 in terms of actual exchange of data. It took quite a bit of time to build consensus and also to raise funding to make things work. I don't have a firm figure on the startup cost. The primary funding came from federal and state grants, a particularly large proportion from state grants. New York has been particularly forward-thinking and has devoted tens of millions of dollars to health IT implementation in its state. There were also in-kind contributions from the competing organizations in Manhattan. What I do know fairly well is the ongoing operating costs. They have a fairly lean operation with only 3.5 FTEs, and the entire technology infrastructure is outsourced as software as a service. So there were a few capital costs and hardware costs, and these are all on a subscription basis, and the annual operating costs are under $1 million. The participants in New York City include Beth Israel, St. Luke's Roosevelt that are part of Continuum Healthcare, the New York Presbyterian System, and NYU Medical Center, as well as St. Vincent's and Mount Sinai, all fiercely competing institutions in an area that's probably less than the area inside Loop 610 here in Houston. In addition, there are some hospitals outside of Manhattan, and there are ambulatory practices and home care and nursing homes that are participants in NICLIX. Now, this chart is probably too small print for each person to see, but the rows represent the types of data feeds that are going into this health information exchange. It includes registration information, allergies, diagnoses, and procedure codes, and it also includes clinical information, laboratory results, radiology, pathology results, cardiology reports, endoscopy reports, and so on. Medication lists are included, as well as EKGs and some radiological images, and especially immunizations and some personal health information. The columns across on the your right-hand side are the different organizations, and the green indicates those data feeds that are live at those organizations where they're providing the information to the Health Information Exchange. So you can see they've made a fair amount of progress. This information on the table is as of October of 2009. The architecture that NICLIX uses is a federated model health information exchange with all the information residing in the organization's data repositories with edge servers that provide information record to a centralized master patient index, provider directory, and record locator service. So there's no central data repository per se for the identifiable information. There are some central repositories for public health information. And then the clinicians that want to view the information on patients across the participating facilities use a clinical portal, web-based portal, or client electronic health record. There is some integration of the information into electronic health records, but a large amount of that is viewed just on the portal. So since February of 2009, shortly after it went live until March of this year, the number of patients, unique patients in the Health Information Exchange has grown from just under 500,000 to 2.5 million. And they observed that the amount of crossover of these patients, in other words, of these 2.5 million patients, those that have been to more than one institution in New York City that's participating in the exchange is about 9%. When they break down the number of institutions visited by these 9% of individuals, there were a significant number, nearly 200,000 that had been to 2 sites. And then the number diminishes, but significantly there were over 50, actually over 80 patients that had been to 7 or more sites among these competing institutions. Now I want to transition over to the costs of not implementing health IT, looking at costs in our community, in hospitals. When we look at the greater Houston context, and we have about 4.5 million people in this area. As Dr. Shine mentioned earlier, over a quarter of population of Texas is uninsured, and Houston is no exception. There's over 1 million, and there's another 500,000 who are underinsured in this region. The data that I have from Kaiser Family Foundation 2008 was 0.4% lower at 25.2, but Dr. Shine had the most recent data at 25.6% uninsured overall in Texas. In the greater Houston area in 2009, the estimates are that there were nearly $2 billion in safety net care delivered. That's a combination of care that was written off and care through charity and safety net sources such as federally qualified health clinic funds and Medicaid funds. Even in this environment, the typical hospital that has over 200 beds in an informal survey of CEOs and CFOs have found that on average, a hospital with at least 200 beds was writing off at least $1 million in uncompensated care each month, or $12 million per year. Some of the larger hospitals in our area, individual facility, write off in excess of $50 million a year. So there's some significant costs here in terms of what is written off. Nationally, well, I mentioned earlier the investment into health information technology. The data that was cited earlier about the adoption of electronic health records is representative of Houston, but I think that we've made significant investments, and there will be a hockey stick phenomenon, hopefully, in the next 18 to 24 months, as a lot of these investments, these products, go live within the institutions and put into daily use by clinicians. But at present, the Houston context is similar to the national hospital context. In a very timely article that was just published last month in Health Affairs by Ashish Jha at Harvard Public Health and Medical School, he indicated that of the meaningful use criteria that were spoken of earlier, the majority of the hospitals in the United States have not exceeded 5 of the meaningful use objectives. In order to fully qualify for the incentive dollars, at this point, there are only about 2.6% of hospitals who would qualify today. I expect that situation in Houston to change significantly based on conversations with chief information officers and CMIOs in town. But today, there's a lot of work to be done. If we look at the individual patient context, it also reveals a lot of work to be done. And this was, in fact, a patient that I saw in a charity clinic very recently, a male that was born in the late 70s who has been HIV positive for probably about half of his life, with the chronic diseases of asthma, bipolar disorder, and seizure disorder in addition to the HIV status. This patient does have a primary care home, a federally qualified health clinic here in town that's actually going live with an electronic medical record in the next quarter. This patient had been seen about 24 to 36 hours prior to appearing in the clinic at a local emergency department that did not have an electronic health record. The patient was seen with an asthma exacerbation, spent 18 hours in the emergency department, was stabilized, and then discharged and told to follow up with their primary care clinic. Except that the primary care clinic was closed on Saturday, and so they came to this particular site. A new patient, first time to be seen, with a history that suggests at least 10 to 12 medications being taken on a chronic basis, but none of the medication bottles and the specifics were available. There was no way to access the information at the FQHC, which was the patient's primary care medical home, nor even the information at the emergency department in a timely fashion. So it was not clear whether this patient was simply HIV positive or had active AIDS and had secondary infections, which may have led to the asthma exacerbation. So the treatment of this was clearly a shot in the dark. The patient said that they had a chest x-ray done at the hospital emergency department, but was not cognizant of the results. So the timeliness of the communication care coordination in this situation was clearly suboptimal, and this happens every single day in our city. Now, the Harris County Medical Society provides some resources for its physicians. This is a web page that provides links to the various health systems information portals for physicians, clinical portals. The emergency department where this patient had been seen prior to appearing in my clinic was not on this list of facilities. In addition, if the patient had been seen at one of these facilities, I would have to be on the medical staff and have a user ID and password into that system in order to access the information. So the existence of this portal is clear recognition of the need for information access by physicians, but we simply don't have the infrastructure in this community to make that happen in a timely fashion. So when we look at the cost of not implementing health IT, what are some future trends for hospitals and our community? Well, again, there's another timely article in this month's issue of Health Affairs by Stephen Pitts, who's a lead study author from Emory University. He looked at emergency care in the United States and identified that emergency physicians constitute 4% of all the physicians in the U.S., but they handle 28% of all the acute care visits. And uninsured patients receive more than half of their care in emergency departments. 2/3 of this care took place on the weekends or after hours on weekdays. And as most of you already know, if you've ever been in an emergency department, there are long waits, the bills are significantly higher than the office, and there's a significant chance in our environment for duplicative tests for patients. In the study, in the article in Health Affairs, Pitts goes on to explain that the Patient Protection and Affordable Care Act, otherwise known as the Healthcare Reform Bill, is expected to expand funding for primary care and increase coverage for an additional 32 million Americans. However, he makes the point that unless the expansion of coverage is matched by growth in primary care capacity, and this speaks to the change in the delivery system that we must have that Dr. Shine referenced, the already crowded emergency departments may actually experience increased visits. And that is in fact the case in the state of Massachusetts, which implemented statewide health insurance coverage back in 2006 because the state was unable to quickly train enough primary care providers. The Boston Globe did a study, and this information is now over a year old, so I don't know if these numbers have since improved. But at that time, after 2 to 3 years of universal coverage in the state of Massachusetts, the patients that had state-subsidized insurance continued to use emergency departments in Massachusetts at a rate that was 14% higher than Massachusetts residents overall. Even the state-subsidized patients that had the lowest incomes, who previously received free care in emergency departments and now had to pay a nominal copayment, continued to use emergency departments at a rate that was 27% higher than the Massachusetts average. When we look at the average charge in the state of Massachusetts, Boston Globe's findings, some of the data is from Blue Cross Blue Shield of Massachusetts, the largest private insurer there. They found that the cost of treating a non-emergency illness in the emergency department was $976 versus $84 to $164 to treat similar ailments in a primary care physician's office. Following along with this idea of increased coverage resulting in increased emergency department visits and not the other way around, Caroline Mortensen also had another article in the same issue this month's Health Affairs that indicated that in some states that have Medicaid co-payments for non-emergency visits to the emergency department, this cost sharing has not had a significant impact on reducing Medicaid enrollees' reliance on emergency departments. So we can anticipate in the demographic data that Dr. Shine cited earlier, and the experience that we've seen in Massachusetts, we can probably anticipate that there's not going to be a significant improvement in emergency department utilization and appropriate utilization of primary care in terms of the population in our region, Greater Houston area, and we will not see economic benefits from the shifting of patients from expensive emergency department care to primary care facilities. Earlier this year, the American College of Emergency Physicians conducted a survey of its members, over 1,800 emergency physicians across the country, and their gestalt was the same. 71% of the emergency physicians expected emergency departments to increase despite the healthcare reform bill. And nearly 2/3 of them don't believe that the new law will effectively address uncompensated care. And I believe that is going to be true in this area, as Dr. Shine referred to, the undocumented individuals in this area. The majority of the emergency physicians surveyed reported crowding in their emergency departments more than half the days of the week, and some of them reported, nearly a quarter of them reported overcrowding in the emergency departments every day. So we will have that situation in Houston as well, I believe. Finally, as we look at the other costs of non-utilization of health information technology, we've talked about the stimulus incentives for providers to adopt healthcare IT. There are also penalties. We mentioned earlier in the McKinsey analysis released last month that EHR implementation in an optimal fashion would cost $80,000 to $100,000 per bed in the hospitals. If these organizations, the hospitals, do not use electronic health records, by 2015, there will be penalties in the range of $2,000 per bed per year that will be assessed on the organizations. And by 2019, those penalties will rise to $35,000 per bed per year. So when we look at the potential return on investment, McKinsey looked at what are hospitals going to get besides avoiding those penalties for their $80,000 to $100,000 per bed investment. Their analysis showed that linking of electronic health records to bed management and resource scheduling software, what some organizations may call business intelligence or enterprise visibility, can save hospitals more than $20,000 per bed per year in labor utilization alone. In addition, the EHRs that have CPOE with clinical decision support can save $18,000 to $15,000 per bed in reduced medication errors and adverse drug events. And then finally, the accurate tracking of the care that's delivered and the coding of the procedures connected, that information coming out of electronic records and clinical information systems into revenue cycle software can help hospitals recover more than $4,000 per bed per year in unbilled services. So there is a path towards revenue recovery or return on investment in the implementation of these expensive systems. I'm going to quickly jump to this last slide to conclude. We've talked about the cost and some of the potential returns. This is an area that requires significantly more discussion than we have time for today, and perhaps we can talk about this some in the question and answer session. But the critical question is the expense of the electronic health record systems and health information exchange for the communities. Who bears the cost? Today, for electronic health records, it's primarily the providers. For health information exchange, thanks to previous AHRQ and other federal government programs and the most recent statewide HIE or Health Information Exchange programs and the Beacon community programs that Dr. Blumenthal spoke of earlier, the federal government is actually paying for somewhere around half of health information exchange activity today, at least the community-wide efforts. And then providers are filling in the rest. But who benefits? Ultimately, the patients benefit from better care, better accessibility to information following the patients as they go to different providers. But the payers also will benefit from improved management and reduced duplication. And by payers, it's not just the insurance companies or the public sources of funding, it's also the employers who pay a significant portion of the bill. In August of this year, just last month, Aetna, Highmark, United Health, and WellPoint announced that they will implement pay-for-performance programs that will align with the stimulus bill's meaningful use criteria to make it easier. And so providing an additional source of funds to providers for the implementation of these electronic health record systems. I'll conclude at this point, and we'll have an opportunity for some discussions. I just want to say that I put this picture up here, partly because I've worked for NASA for nearly 10 years now, but in that time I've seen the growth of the International Space Station from just a few modules to what you see here in this photograph. And in this time, the United States, the European, the Japanese, the Canadian, and yes, the Russian space agencies have learned to share clinical data on their astronauts and live and work together in the National Space Station. And we are doing research jointly to improve the health outcomes for astronauts in long-duration space flight, trips to the moon, should we get the funding for that. If this can be done among former Cold War folks across the different sides of the wall, I think we must be able to find a way to bridge the organizations in Houston and to collaborate for the benefit of our community. Thank you very much.
Thank you very much, Dr. Joe, and I'd like to go ahead and open the floor to questions. If anybody would like to ask Dr. Shine or Dr. Joe any questions, do we have any interested folks? We have one right over here.
Thank you both. Per Dr. Joe, since the cost in the emergency rooms, and many of these emergency rooms are contracted, have they started thinking about any other models? Most people have the perception that they want to go where they have access to a doctor versus a PA at a Walmart or a Walgreens. So are they thinking about any other models where they could have triage and then a sub-facility versus a more expensive electronic medical facility, associated with the hospital? And then per Dr. Shine, a question to you with respect to all of our institutions here have a lot of clinical studies, which include the need to share information with companies as we're dealing with innovation, but also other countries as we have this challenge with FDA, where we're not getting everything cleared for care. Many of our studies are going overseas into other countries. So thank you. Deborah Mansfield, Houston Technology Center.
Regarding the emergency room utilization and lower cost venues of care, I think the cost of electronic health record technology is going to be similar across the emergency department and the maybe community emergency center, with the possible exception of the large hospital emergency departments, where those costs, they're more complex systems, information systems, that are more expensive. In a number of articles, I think including the Health Affairs article that I cited earlier, there was discussion about the use of lower cost and mid-level providers, the retail clinics and so forth. So I think that change in our healthcare marketplace is being driven by market economics, and I think that is going to continue to occur.
Let me comment about the emergency room issue as well. There are a number of people in this room know that we've been sponsoring, in collaboration with the Baker Institute, the Texas Medical Association, Hospital Association, Nursing Association, and the Department of Health Services, a series of workshops on call for the health of Texas. We concluded one of these last week on emergency room performance. And I would just emphasize several things, all of which are entirely consistent with Dr. Joe's presentation. But first, improving emergency room performance requires that you look at it as a system of care that begins well before somebody calls 911, but includes the pre-hospital care, the time in the hospital, and the time after discharge. That's a systems engineering problem, and we're beginning to approach that with systems engineering. Guess what? It requires data. One of the more interesting experiments is right here in Houston, where the hospital district looked at the use of emergency vehicles for people who are calling in who are frequent flyers, people who are using the system often. Guess what the most frequent reason for a 911 call to get an ambulance to take you to the hospital was when they looked at those people who were frequent flyers? I'm sorry? Out of my medication. Close. What? They didn't have transportation. And so whatever the reason was that they had required care, which could have been just a consultation or get the prescription filled, they didn't have transportation. And so for certain 911 calls, the screeners now send a taxi. It turns out, this is honest to God truth, they've got good data. And the point is that so far as we can tell, it's not impaired the outcome of care. Similarly, there are individuals who come to the emergency room who are frequent flyers who don't need an emergency room workup. But you hate to send them home because you have reason to believe they don't have insurance, for example, they may not follow up. So San Antonio has a certain number of slots set up in their outpatient facility that are owned by the emergency room. And the emergency room can tell the patient, if you come back tomorrow morning at 9 o'clock, you will be seen. And the overwhelming proportion of patients will leave the emergency room and come back at 9 o'clock the following day. I could go on. There are all kinds of other examples. But the key, again, is information. The second point I would like to emphasize is Dr. Joe showed you great data on the cost per bed and the cost-benefit ratio. And he showed you data about the benefit that might accrue from better bed utilization. Guess what? That's about data. That's about it's a systems approach to how you use beds. Similarly, the medication error business. But remember, what I would argue is that the reasons that hospitals are going to have to do this is not going to be measured by the per bed return on investment. It's going to be measured whether they're going to be players in the larger changes in the way in which healthcare is delivered. So I would argue that the hospital, and for that matter, the physicians who are going to be involved in this, have a real interest in doing something, because otherwise they're not going to be players. And I think that's a critical element of it. And the final point I'd make is, as far as the Massachusetts experience is concerned, again, Dr. Joe showed you some very nice data, but one thing he didn't tell you, which is a very significant interest, in Massachusetts, the time for anybody to get an appointment with a primary care provider went from 32 to 53 days. So what was happening is, even if I had insurance before, because of this crowding out effect with all these other folks, the length of my time to see the doctor increased significantly. So when you provide additional coverage like this, you have a real impact on what happens to other people in the middle class. In any case, if you're interested, if you go to the website for the Health of Texas, you can see a summary of the emergency room meeting, which was held last week, which goes to a lot of the issues that were raised very appropriately by Dr. Joe. As far as the FDA issue is concerned, clearly a major problem. On the one hand, there certainly have been a variety of efforts made to improve the potential performance of academic health centers in this country and the CROs in this country to do these trials, but there's a very critical patient care quality issue here, and that is that the FDA used to be reluctant to approve any drug which didn't have a clinical trial in the United States. It's become increasingly clear that with the cost of clinical trials escalating, they can do them far less expensively offshore, not just in India, but in Europe and a variety of other places. So from a patient care point of view, if you do a large clinical trial, and the Italians are very good at it, for example, for heart disease, and it shows a real benefit, then how does the FDA get away with insisting that there also be a trial in this country as long as the data is very good? And the answer is, increasingly they would be willing to accept that Italian study, and since it costs significantly less, you're going to see drug companies do it increasingly. Unless there's some change in the cost structure, I don't see that changing particularly. I mean, I think it's a serious problem, but I don't see an instant solution to it when you look at it from the point of view that the quality of the studies offshore continues to improve and the cost is considerably less than it is here. Do you have any other questions? You have a question over here?
I was going to say I came from an Ohio system before in Columbus, and that's why I knew the taxi answer, because we actually asked patients, well, why are you using the ambulance? Well, because they didn't have taxi money. And they asked patients, well, would they go to a different clinic? And they would, if it was right next door to the ER. So that's what they did. They put their clinics right next door. I mean, they could walk down the hallway to their clinic.
In 28 states, there's legislation pending, and I suspect it's going to happen in this legislative session in Texas, which would dramatically alter the scope of practice for nurses. Because with increasing coverage, you're going to see enormous pressure to allow nurses to do much more primary care, and the question is going to be under what circumstances and so forth. And although we take no position with regard to the legislative issue here with regard to scope of practice, I think to ignore the notion that you're going to see major changes in the way practice is offered, and the fact is that the Walmart model is going to expand. There are lots of people who have a lot of confidence in that for certain kinds of primary care issues. And under those circumstances, again, you're going to have to ask yourself some questions. To what extent do they have access to electronic information?
Let's see, do we have time for another question? One more question?
You started off with a discussion of some of the economics. Actually, both of you touched heavily on the economics of this. And then you moved to this idea of the systems view. One of the things I've seen as a systems scientist looking at this, or looking at a lot of issues, is the role of an externality. And it was your last chart, Dr. Joe, really pointed out. One party bears the cost, another party gets the benefit. And I see this all throughout the medical system where you can mandate something's going to happen or not mandate it, but if the cost isn't borne by the person that's getting the benefit, then it breaks this ROI model that everybody's using all the time to try to do a business analysis of these cases. And so I'm wondering how much that plays a role in your analysis of the financials and externality aspects.
Yeah, I think the ideal model has not been determined. This is a work in progress in various communities. You see in some states, such as Massachusetts, significant involvement by payers and employers. California is similar. A lot of employers have entered into pilot projects for, say, telemedicine or e-visits with their employees, and paying for those and working with their payers so that those models of care are reimbursed. In Texas, though, I don't see as much activity in that front, and I use that last slide in hopes to stimulate some discussion among the various parties, providers, patient representatives, employers, and the payer community, to see what we can work out and what creative solutions we can find here.
Very interesting set of problems. We have in the University of Texas a program in clinical effectiveness and patient safety, which has had over 600, almost 660 participants from across the campus's faculty and staff. They all have to do a research project while they're doing it. And we've had 260 projects to improve safety or effectiveness. And we do an economic analysis with each one. And there is a significant number, perhaps a third, where the hospital saves money. If it's a DRG kind of situation and you can shorten the length of stay, the hospital saves money. There have been a few in which the doctors benefit, but very few. Most of the time when you control the costs, it's the insurer who saves the money or a third-party payer. And therein lies the rub. The kinds of changes that I'm talking about, such as bundling of care, health homes, accountable care organizations, whatever, gain sharing, are all attempts to realign the incentives so that if you save money, you make a profit. You get something out of it. And if you pay $100,000, and I'm just making that up, $100,000 for a hip for 2 years, and you can do that for $90,000, then there needs to be a deal where either you, when you say, I say you, everybody in the bundle gets the $10,000, or it could be that there's a share to the insurance company and there's a share in a premium refund to the people being insured in the full carrying out of that activity. In the case of health homes, the model we're looking at is a capitated model for about 40% of the value, a fee for service for 60%. Okay, so you're still paying fee for service for certain kinds of things, but if you can keep the overall costs less than the per capita than the capitated portion, you make a profit, and you can distribute that by formula beforehand. I think it was Don Berwick, the current head of CMS, who once pointed out that the American healthcare system delivers exactly what it was designed to deliver. And that in fact what happens is When there's a third party paying for something, that it doesn't deliver the benefit to the person or the entity that actually saves the money, and that's got to change. Gain sharing is another example, and it's interesting, if you listen to the people in San Antonio, the hospital there was not principally trying to save money by bundling orthopedic procedures. It was hoping to lower the overall cost so that it would increase their market share. The doctors were very reluctant to get into it because they thought that it was all about saving money and that they were going to get hurt. What actually happened was they reduced their costs. The doctors actually have made more money from it, and the hospital market share didn't change one whit because people tend to go where their doctor refers them for care, and people aren't attracted particularly in spite of one. By and large, people don't shop for price. They don't go to a particular place because the cost for a knee is less than someplace else. So in that particular case, the doctors who were initially very reluctant to do it now are very happy because the incentives got aligned.
Well, great. Thank you very much. Can you all join me in thanking our presenters?
I'd also like to thank our afternoon panel. That was an excellent presentation. And I'd like to thank all of you for coming and listening and providing such provocative, interesting questions. We'll be emailing you a survey to just get your feedback on the conference. If you're not on our mailing list, please let us know. We'd be happy to keep you in touch in terms of future conferences. Thank you.